So the sound there is something called stridor, and in this infant with work of breathing, that is an abnormal sound that definitely needs evaluated by a pediatrician. The problem is infants make noises when they breathe, and sometimes it's normal and sometimes it's not. Differentiating the two can be really important, but also really difficult. My name is Brandon. I am a pediatrician and pediatric ICU doc, and today we're going to talk through what's normal, what's not, and how to tell the difference. All right, so to start out, we're gonna do a super quick anatomy review. The most important thing in this picture, we're looking from the side. We've got the tongue in the front, and in the back of the throat, two structures to note. One is called the trachea, and this is what takes air from the mouth and nose down into the lungs. And behind that is the esophagus, which takes food and liquid from the mouth down into the stomach. There's a critical structure here up top, which is called the epiglottis. Epi means above, and glottis is sometimes a word that we refer to as the opening to the trachea, or in between the vocal cords. So the epiglottis is this flap of tissue that essentially is normally sitting up behind the tongue, but when we swallow, it comes down and covers the trachea to make sure that no food and no liquid gets inside. So it really prevents you essentially from choking, or the word we use is aspirating, when you get liquid or food into your trachea and down into your lungs. So this is a quick video showing that happening, where the epiglottis starts up here, comes down, covers the trachea so that the food goes down into the esophagus and then into the stomach. The only other structures that you probably need to know about are what are called the tonsils or adenoids. And basically there's a bunch of tissue in the back of your throat. It's a ring of tissue that's called lymphatic tissue. Lymphatic tissues are filled with immune cells that swell during illness and really fight off infection. Okay, so let's just hop right into the different sounds. The first one that's pretty common is a congested or sort of snuffling sound. The second is stertor, which is a low-pitched sound. And the third is stridor, which is a high-pitched sound. Okay, so other than just being a super cute baby, this is a great example of that sort of congested sound, especially there at the end when the child's starting a little bit excited. You can kind of hear it, just like the sound of like, man, you got something in the back of your throat, clear your throat. Where it's either in the throat or in the nose, kind of hard to tell, but it's just this sort of mild, congested or snuffly sound. The sound is extremely common, mostly in newborns for the first couple weeks, but you can really continue to hear it for the first 6 months of life. And so what causes it? Well, is just mucus production. So it could just be normal mucus production. For you or I, when we have mucus, it doesn't really affect us because the size of our oropharynx and nasopharynx is big enough that you just don't hear it all the time. And every once in a while you or somebody clears their nose or throat and they take care of that mucus. But for babies, since everything is so small, even a little bit of mucus can make noisy breathing that sounds unusual. Of course, it might not just be normal mucus production, but if you have an acute respiratory infection or an upper respiratory infection, this would cause increased mucus production and louder breathing. So in general, if a baby's doing fine, they're happy, playful like the one in the video, then maybe nothing's really needed. But if a kid is sick and you wanted to suction some of that mucus out, it wouldn't be unreasonable. As always though, just don't overdo it. So we always say to put in like a drop or two of saline, which can help soften up the mucus, and then either use a bulb suction or a nasal aspirator that can help to get that mucus out. But in general, don't do it too deep. That can sometimes cause trauma to the tissue there, which would actually make swelling worse and then maybe obstruct airflow a little bit, which would be bad. And you don't want to do it too frequently either. Sometimes maybe just before feeds or before sleep could be reasonable. Okay, so mucus can cause that sort of congested snuffling sound, but reflux actually can too. So you can imagine that if a baby has some milk or formula that's kind of stuck in the back of their throat, then you would get that similar sound. So what is reflux? Well, it's super common, and basically the esophagus is connected to the stomach, and it involves this muscle or a sphincter between the stomach and the esophagus. It's called the lower esophageal sphincter. And it's basically a muscle that holds tight to allow food and liquid to go down, but not have them come back up or get regurgitated. Now, parents, anybody who has seen a baby who's fed knows that this muscle is not super strong all the time because they'll see spit up, so formula or milk will come back up. Well, you can imagine that even if you don't see spit up, or if you do, that some of that milk or formula can just get stuck in the back of the throat and cause that gurgling or sort of congested sound. In general, if you have a baby like the baby in the video who is feeding normally, not working to breathe, growing normally, and they're just kind of happy and laying there, then nothing necessarily needs to happen. But if it becomes a problem, then there are some behavioral interventions that can be helpful. So, keeping a baby upright for 20 to 30 minutes after a feed, sometimes thickening feeds if the pediatrician suggests it will be helpful. Of course, avoiding cigarette smoke, this is actually really important. That can lead to worsened reflux. There's some evidence that if you've switched to formula feeds, that maybe doing breast milk for a little bit longer can be helpful. It can help the stomach empty out a little bit faster. And then just avoiding overfeeding. This is most important for babies who are getting bottle fed rather than breastfed, but just something to think about. Okay, so I think that should cover congestion. Now let's talk about stertor. So stertor is a sort of like snoring sound that's either
in the back of the throat like that, or in the nose, or kind of in the nasopharynx like that. Sorry. And so I found a pretty good example of stertor online. Okay, so obviously I probably could have found a human example, but it really sounds the same as in this dog, and I thought it was really cute that it snored itself awake. But you can just hear it's that sound. It's a snoring sound essentially, and it's really just tissue that's rubbing on top of itself. So either the nasal turbinates are kind of rubbing together and vibrating, or there's some tissue in the back of the throat that's just vibrating around and making that noise. So in infants, to be honest, this isn't as common, and you usually don't have to do anything about it, but as kids get older, it's not uncommon to have recurrent infections, recurrent strep throat, for example, or actually develop sleep apnea. And this can sometimes be a sign that those lymphatic tissues, the tonsils and adenoids in the back of the throat, are too big or too inflamed. And so here, you got a picture of an older child, of course, because they have teeth, but you can see these two big structures in the back. We call those well, it's tonsillar hypertrophy, but we call them almost kissing tonsils, where sometimes tonsils are like, oh my gosh, they're almost going to come together and touch each other. And so you can imagine that can lead to obstruction in airflow, and so sometimes you'll need to undergo a tonsillectomy and adenoidectomy, where they actually take the tonsils out and take the adenoids out. Okay, and we'll do our final sound, which is called stridor, and it sounds something like this. And so in this case, so rather than this kind of rumbling sound in the back of the nose or the throat, this is actually in the voice box itself. So the two diagnoses I want to talk about both kind of cause the same thing, where there's obstruction to flow right at the entry of the trachea, which we call the voice box or the larynx. One is croup and the other is laryngomalacia. So we'll start here by listening to a baby who has stridor. As an example of croup, I will say this child I don't think was actually diagnosed with it, but the sound is exactly what you would hear with a child who had croup. So you can just hear, every time the child breathes out, they do this really fast and high-pitched in. That is a classic example of stridor. And then this one's specific to croup, but it's an example of what we call a seal-like barking cough. Okay, so that one I'm actually not going to try to imitate. There are some pediatricians I know who can do that really well. I'm not as good at it, but that is a classic cough that you will hear with croup. And so what's happening with croup? Well, croup, another word for it is laryngotracheitis. And so remember, laryngo, larynx, that's the voice box. Trachea is the trachea or the windpipe, and itis means inflammation. So laryngotracheitis, or inflammation of the larynx and the trachea. So in the picture shown here, you can just imagine that this is the voice box, and if the vocal cords and the larynx and the tube around it are swollen, then there's going to be less room for air to pass through, and you're going to get this whistling sound. So what's really important about it? Well, one, it's normally a viral infection, so an upper respiratory tract infection that gets down into the voice box. It's commonly caused by a virus called parainfluenza, but other viruses can cause it, like rhinovirus or RSV. We don't usually treat the virus directly, but again, similar to bronchiolitis, we do supportive care. Specifically, we give steroids, which can reduce swelling or inflammation, and then if it's really bad, we can also give what's called racemic epinephrine. So epinephrine, the baby basically breathes this in. It's a nebulized medicine that goes in through a mask, and the epinephrine actually constricts the blood vessels in the voice box to open them up a little bit and reduce swelling as well. Okay, so that was stridor in an acute patient. So didn't have stridor before, but now suddenly has an infection and something going on. But let's look at stridor in a more chronic presentation. So really present from the first 2 weeks of life and continue for a couple months. So in that example, you could hear it, multiple times that there was stridor. And especially in that last example, you just heard that with every breath in. So what's going on here? Well, this is a diagnosis of what's called laryngomalacia. So again, breaking down these words, malacia usually just means kind of like malformed, and laryngo, again, means like something to do with the voice box. And in this case, we're actually talking about the epiglottis and how that's formed. So once again, this is that structure that drops down over the trachea to protect it when we're swallowing food or liquid. And in this case, it's just bigger and floppier than it normally would be. So in general, this presents within the first 2 weeks of life, usually peaks in symptoms around 4 to 6 months, and tends to self-resolve by 12 to 24 months. You can imagine that the issue here is just that you have this kind of big floppy structure that's on top of the entryway to the lungs, and that's making that whistling stridor.
A critical thing to note, and it was true for this baby in the video, that when the baby's on their back, it tends to be worse. Because again, this structure is normally sitting up like this, but when we go on our back, it's gonna flop down just with gravity. In general, babies who have this should be evaluated by an ENT, but most of them, 80 to 90%, won't need surgery, but 10 to 20% will undergo what's called a supraglottoplasty. And you'd have to talk to an ENT about this, but this is basically where they fix up the epiglottis so that it doesn't fall down over the trachea when the baby's trying to breathe. Okay, so the last point I want to make is, how does your pediatrician think about whether further evaluation, referral, or anything else is needed? In general, and this is probably true for a lot of pediatrics, is things are a problem when they're a problem. And so what does that mean? Well, if a child has some noisy breathing, maybe some congested sound, but they're breathing normally without effort, they're happy-go-lucky, not having any issues, their skin is normal and a healthy color, they have good oxygenation when they check on a pulse oximeter, they're feeding normally, and they're gaining weight, well, those are all signs that things are probably going okay, and you may be able to defer evaluation. But whenever in doubt, then of course, having further workup is important. I want to point out two things from this list. So one is feeding normally, and one is gaining weight. So for the feeding normally, why is this important? Well, this is just to emphasize. Remember that when a baby has a nipple or a bottle in their mouth for, say, 20 minutes at a time, they can only breathe through their nose. This is why babies are obligate nasal breathers and really prefer to breathe through their nose rather than their mouth. So if they're able to get milk in and breathe through their nose for 20 or 30 minutes at a time, then that's a really good sign that they're able to move effective air. The other thing to know is that when a baby's feeding, that is really like baby exercise. So they are exerting themselves more during that period than they are the rest of the day. And then finally, to coordinate that suck, swallow, breathe reflex can be difficult. So you have to suck milk out of the breast or bottle, you have to swallow it into your stomach, and then you have to breathe pretty rapidly in between those two actions. So if a baby's doing that and they're not having issues, so they're not coughing, they're not sputtering, they're able to last on the breast or bottle, for 15, 20 minutes, then that's usually a good sign that they're moving air pretty well. And then gaining weight. So first, if you're breastfeeding, for example, it can sometimes be hard to know. Like, okay, well, we breastfed, but I don't really know how much milk the baby got. Well, if he or she is growing normally on their curve, then that's a sign that they are getting adequate nutrition. And the second thing is that, let's say a baby's making some funny noises or abnormal noises, and they're breathing a little fast. They're breathing a little hard, but it's not that bad, and you're trying to figure out how big a problem is this. Well, oftentimes, it's a good sign if the baby is growing normally along their curve. Because what it means is, however fast they're breathing, they're not actually dedicating that much energy to doing it. It can sometimes be a concern if you see a baby start to fall off the growth curves or even lose weight. That can be a sign that, man, they're actually using a lot of their metabolic demand. They're actually using a lot of the energy that they're getting to breathe rather than grow, which is what they should be doing. Okay, so similar to other videos, the purpose of this slide is really just to emphasize that there are a lot of things that can cause abnormal breathing sounds in infants. We've talked about a couple of the more common ones today, but this is definitely not an exhaustive list. And in modern medicine, there's a reason that ENTs exist. So if there's a concern, having them evaluated by a specialist is quite important. Okay, so I think that's all I have to say about normal and abnormal breathing sounds in infants for now. What I would ask is you can like and subscribe, that's awesome. But more than that, if you're willing to put a comment with any questions you have about pediatric topics, whether intensive care unit, emergency medicine, or normal happy babies, I would love to explore them with you. This video actually came from somebody making a comment, so I really appreciate that. And yeah, I hope this is all helpful, and see you on the next one.